have Dr. Ghanshyam Goyal, who has come all the way from Kolkata, and he will be talking about diabetic foot ulcer, the clinical approach. And to have this session, we have chairperson Dr. Sanjay Rastogi. Dr. Sanjay Rastogi, kindly come on the dais. Dr. R.K. Nigam and Dr. A.K. Agrawal. Over to chairperson.
Mike.
Chairperson sir, thanks team KDACON for inviting me. I am going to discuss diabetic foot ulcer clinician's approach. As we all are aware, medium time to healing a DFU is around 12 years, breast, CA, prostate and all that. And still the mortality is very high. This is a recent review by David Armstrong and Andrew Bolton, and what they have shown, every year there is around 18.6 million people worldwide had associated with increased rate of amputation and death on account of diabetic foot ulcers. And what they find, reducing the pressure from the weight-bearing area, lower extremity ischemia to be tackled, and that foot infection to be treated, and early multidisciplinary approach can lead to the good recovery and improve the outcomes in diabetic foot ulcer. So this is a common scenario. We all know in detail in clinical practice, unsuccessful home therapy, visit to local physician, application of unproven remedies, and lead to the second visit to primary care center, district hospital, regional hospital, not aware of the management of diabetic foot, and leading to sepsis because of delays, and ultimately refer to the specialist care, and where the gangrene is set up, systemic infection is there, and lead to the either minor or even the major amputation that is there. So what are the basic tenets of diabetic foot management? Always remember, whenever we do, and you all are aware of it, adequate debridement and infection control, adequate vascularity, and adequate offloading. So neuropathic foot, all we know, it is in the high pressure areas which are there. These are the high pressure areas where we will find it. Then it is the blunt callus which is there, and to have a callus we need a very good blood supply, and lacks the protective sensation, loss of protective sensation. Our neuroischemic or ischemic foot, it is generally black or pulseless, and it is very painful. So by that you can differentiate. This is another paper recently by the diabetic foot ulcer, appraising standard of care and reviewing the new trends in management. So as I have already discussed, there are 4 basic principles. One is the pressure relief or offloading, then debridement, then infection control, and revascularization if indicated. Even it has been shown that even with the standard of care, the many DFU persist and they doesn't heal. In that situation, what you have to go for that? So you have to use the novel therapies, which are known as advanced wound care modalities, including the negative pressure wound therapy, biotin, hyperbaric oxygen therapy. So instead of discussing the clinician approach for diabetic foot ulcer, I am going to discuss regarding the how to handle non-healing diabetic foot ulcers. So what is the how to define healing of foot ulcers less than 15% per week or less than 50% in 4 weeks is called as non-healing diabetic foot ulcer. And what are the causes? One is diabetic neuropathy, vascular disease, multi-drug resistant diabetic foot infection, diabetic foot osteomyelitis, and clogging of toes. And this is a use of advanced technology of wound healing when you are going to have it. Just look, measure the reduction in the size of the ulcer, 15% every week or 50% in 4 weeks. If everything is fine, yes, continue the same. And if patient is not having adequate healing, less than 50% in 4 weeks, then you have to look for the assess, reassess, check for infection, circulation, compliance, and if everything is fine, then advance to the advanced modalities. So this is known as percent area reduction. Percent of patients who ulcer heal during the first 12 weeks, if the healing rates, PAR, percent area reduction is more than 50%, the healing rate is got high in comparison to the patients who have not healed the ulcer. And these are the 2 studies. In one study, 133 patients, another it is 117 patients, and it was found that a patient in whom in first 4 weeks the the reduction in the ulcer size was more than 50%, healing rates were more than 57%, while in the ulcer healing rates were less than 5% in the other group, where the percent area reduction was less than 50%. So how will approach? One is the advanced modalities, then surgery, and then the palliative therapy. So what is the advanced total contact cast? We all know it's a gold standard, made of plaster of fiberglass cast material. How it works, we all know. It uses a plantar pressure, and this is one of the cases. Is a sharp push foot with the midfoot ulcer, and you can see multiple fractures of the tarsal bones, and there is exostosis. If patient was given the posterior slab, because patient was not able to have it, it's a highly exudating wound. So we cannot give the total contact cast. We have given the posterior slab, regular dressing, and find that ulcer was healed in 6 weeks. And then we subject the patient for exostectomy. You can see this was the patient where this is the region. So we have subject the patient for exostectomy, and even you see after 5 years follow-up, there is no recurrence of ulcer. So this is the one of the important aspects we have to know. And the another is non-healing ulcers since more than 3 years. Skin grafting has been done, and we all know the healing ulcers heal very difficultly. So in that situation, we have given a modified total contact cast with window walking. And in that situation, ulcer healed, but it took practically 5 months. Practically more than 1.5 years. So it has been healed, and we will continue with this with the standard of care and the total contact cast with modified total contact cast with the window walking cast. And this is another review article in 2017 that benefits and risks of total cast in the management of diabetic foot ulcer. And what has been found, we all know it's a gold standard, but still people are using less and less. So we have to recommend the more use of the total contact cast. Around the globe, around hardly 2% of clinics use the total contact cast. The indigenous technique of offloading, I think everybody is using, even in the primary care center you can use, take a piece of piece of foam, wrap in a piece of gauze and stick with the micropore, and by that you can offload. Because most of the ulcers, I am just going to show you later on, in our country are around 80% are neuropathic, 20% are neuroischemic or ischemic ulcer, while in the western part it is 1/3, 1/3, 1/3. Means 1/3 neuroischemic, 1/3 ischemic, and 1/3 neuropathic. This is another way of giving the total contact posterior slab with the indigenous technique of offloading. We have named it as SK offloading. So this is the guidelines from the International Working Group on Diabetic Foot. In 2023 is updated. Dr. Vijay is one of the who is the president of now elect RSSDI, who is also the one of the part of these guidelines. And what they have suggested, you see, if a person who is having plantar forefoot or midfoot ulcer, no infection or ischemia present, use a non-removable knee-high offloading device. Or if a person who is having heel ulcer, is non-removable knee-high offloading device. But if patient is unable to tolerate, in that situation, you have to use a knee-high but removable cast. But the compliance is very important. You have to force, as we have used in the second patient, which I have shown you, that it was a highly exudating wound. So we have to have a regular dressing. So that's why we have given a posterior slab and regular dressing was done. So about the compression bandage, you know, varicose ulcer is a very big problem now all across the globe, and this 4-layer compression bandage gives fantastic results. One is orthopedic wool, crepe, and elastic bandage, all these parts, and we give it, we have done to around 700 patients, and we find fantastic results. Ulcer generally heal in average 3 months of time. Sometimes if the ulcer is smaller, around 4 weeks, otherwise maybe 8 weeks, 6 to 8 weeks. And this is another article where effecting a 4-layer compression bandage in comparison with the class 3 compression hosiery. So it was found the healing is much earlier than in comparison to the 3 compression hosiery, but at the end of 24 weeks. But otherwise healing rates are much higher than the 4-layer bandages. So about negative pressure wound therapy, I think everybody in this gathering is using it, and how it is worked. It is by applying the subatmospheric pressure to reduce the inflammatory exudate and promote granulation tissue. This is the LPWT or vacuum closure. You can put it in these ulcers, and you see this is a presentation 50 years, came with the gangrene of second, third and fourth toe, extend up to ankle, debridement has been done, and then the wax has been put here, and then the skin graft with the meshed skin graft was done, and now at the end of 12 weeks you can see the healing of the ulcers. So, systemic review and meta-analysis of efficacy and safety of negative pressure wound therapy in the treatment of diabetic foot ulcer, and it is now 9 studies where more than 943 participants, and it has been shown it effectively accelerates the wound healing, which is equally safe with general routine treatment. And then about the topical wound access therapy, it is very much available in our country. I think most of a few of you might be using this. And chronic wounds are typically progressed being hypoxia, that partial pressure of oxygen. And in context to the critical level, at the mid, there is a critical level of threshold for the enzymatic process to take, and if you supplement with the local or topical oxygen, this heals in the healing of the wounds. So this is the setup how you will give. This is a hyper box. This is a 10-liter oxygen concentrate, not the 5 liters which we are using in routine. And then you can have this boot, and you can give it 90 minutes per day, 5 days, 4 to 5 days in a week, around 3 to 4 weeks, and it accelerates the healing. This patient came to us from Bangladesh. He was non-healing ulcer since more than 2 years. It was not healing, and we have given this topical oxygen therapy for around 3 weeks, and ulcer healed. So, topical wound oxygen therapy in treatment of chronic diabetic foot ulcers, and right from the Robert Friedberg, who is one of the greatest ankle and foot surgeons from US, and what he has mentioned, that not all wounds are suitable for TOT, and not all wounds thus treated will heal. This therapy is certainly not a panacea. Remember, mind, it's not a panacea, but however, when you adjunctively with optimal wound care, means standard of care, then studies provide clinical evidence necessary to support of use of topical oxygen in the management of chronic DFUs, and now it is approved by the FDA also. That is it. About the PDGF, I think we are using since more than 15 or rather might be 20 years. First in India it was available in 2004. So it is there, but only thing is if you are using it, then you have to follow the standard of care. Means adequate debridement, infection control, adequate vascularity, and adequate offloading. If you will not offload these, it is not going to work. So that is it. And this is from the Indian study of platelet growth factor in wound healing of diabetic foot ulcer in Indian population, and what they have shown, the recombinant human platelet growth factor improves the healing in comparison to the normal dressings, and which is statistically significant. Then the PRP, platelet plasma, actually people are using for a lot of things, osteoarthritis, even for me like person, for bald persons, even for the hair growth and all that. So PRP we have used in a lot of patients with diabetic foot ulcers which were not healing, and how it works, because it's an autologous platelet-rich plasma. We take the blood from the patient, around 18 ml and 2 ml of the anticoagulant, and it is a lot of PDGF, then vascular endothelial growth factors, then epidermal growth factors, insulin-like growth factors. And how you can do? You take the sample, and this is the kit where you can see this is the kit, and this is the Buffy code, this is the RBC, and this is the platelet poor plasma. Take it in the syringe and inject locally, and it is going to foster the healing in these patients. Do it weekly. So there is a paper in support. There is evidence in favor of this treatment of non-healing diabetic foot ulcer with platelet-rich plasma. And in spite of these standard measures, some non-healing ulcers need additional growth factors for healing. So autologous platelet-rich plasma is easy and cost-effective method in treating diabetic foot ulcer, as it provides necessary growth factors with the enriching healing. So patients even respond. You have done everything. Means you have done standard of care, and even patient's ulcer is not healing. In that situation, you can use this sort of modality. So platelet-rich plasma for treatment of clean diabetic foot ulcer. And what was the conclusion according to this paper? Autologous platelet gel is more effective than the local antiseptic dressings in terms of healing rate and prevention of infection in clean diabetic ulcers. So very important. So infection is controlled. About this, the dermal matrix, I think it's a new thing we are using. We have recently used in 5-6 patients, and we find it's made of the bovine, the collagen layer, and other is from the silicone layer or elastin layer. The different companies have made it, and it provides a scaffold to restore skin and modulate scar formation. So this is the evidences in favor of dermal matrix. that dermal substitute with split skin grafting was adopted. You can use with skin grafting or without skin grafting. We have used without skin grafting with 5-6 patients, and you find fantastic results. And then comes the surgical offloading. So why we are doing this medical offloading, surgical offloading? And surgical offloading is done in patients with pre-ulcerative changes who have failed corrective measures, or in those who are the uncomplicated ulcers are there. So flexitinotomy. So this is very important. Always remember, if you are planning to have a flexitinotomy, you can do in your clinic. You doesn't require anesthesia, no any OT setup. Only thing is just palpate the pulses, and pedal pulses should be palpable. Means adequate vascularity is there. So if the dorsalis pedis and tibialis posterior are palpable, then do a, suppose you want to do a third toy flexitinotomy, just take a 18 gauge needle and cut the tendon of flexite restorer, and by that it will straighten and offloading will be done. So fantastic. We have done around more than 100 patients of flexitinotomy in our last 25 years of practice, and these are the evidences in favor of that. Outpatient percutaneous flexitinotomy is for management of diabetic clot or deformity with ulcers. So percutaneous flexitinotomy is safe and effective procedure that can be performed in a clinical setting. It aids in rapid healing of recurrent ulcer on the tips of the toe or deformed diabetic patient. There is even patient with osteomyelitis. Suppose it is due to chronic ulcer with osteomyelitis. It's not a contraindication. You can do it still. It is going to take some time. You have to give an antibiotic ranging from up to 6 weeks of time, but it is going to heal. So that is very important. It's a very good modality you can use in your clinical practice. So here I'll show you. This is the patient who was there. And then we have debrided, done the flexitinotomy, and the healing has been done. Kaler's arthroplasty, this has to be done by the surgeon, because 1/3 of the ulcers occur on the great toe. Out of all the foot ulcers, 1/3 occurs at the great toe. So in that situation, due to the limited joint mobility. So what is there in that situation? What you will do? You remove the proximal phalanx, proximal hand, cut it, and by that movement will increase, and that will help in reducing the ulcers. So dear friends, to conclude, it is from the physician's point of view, diabetic foot examination mandate in all diabetic patients. Physician should examine a diabetic patient from foot to head, apadamastak always, because we start our examination from head to foot. So instead of that, we should start our examination from foot to head. So we are not going to miss the diabetic foot. Physician should identify the high risk fit. This is the dictum of the day, and team members of the physician should impart foot care education to all diabetic patients at every visit. And then non-healing diabetic foot ulcer is a common clinical problem. PAR, percent area reduction in 4 weeks, is a powerful indicator of wound healing. Recent modalities, VAC, topical wound oxygen therapy, PRP, PDGF, development matrix, all modalities help in non-healing diabetic foot ulcers. Surgical procedures, especially operative techniques, one is the Kaler's arthroplasty or flexitinotomies are very useful. But above all, the basic principles of wound healing are the managed of your few. Thank you very much for giving patience here.
She's in the next.
She's not in this. Take out more.
She's not in this one. She's in the next. Yeah,